What the breath sounds mean, shall we? Let me stand up. I wish I had a pointer because I would be, I do have a pointer. Let's turn this darn thing off. I'm obviously technologically impaired today because it won't work. And I have a pointer, like this.
A pen?
Whoa! Crackles! Can everybody see?
Mm-hmm.
Crackles are fine, high-pitched crackling or popping noises. Sort of like that paper, that bubble paper that you get in packages. And they are discontinuous sounds. So they can be heard during inspiration and sometimes during expiration, but not always. So if they're not cleared by cough or altered by changes in the body position. So they're also called rails. That's another way that you could document them. Remember, crackles can be heard in the front lung fields or in the back. You are not going to be proficient in lung sounds when you graduate this program. So you might as well get that out of your heads right now. It probably took me a good year, maybe, practicing on a med-surg floor to get proficient in breath sounds. Sometimes I'd be so confused I wouldn't know what it was. I'd have to go get another nurse and be like, hey, look, I have no idea what this is, but this sounds bad. I knew it was abnormal, but I didn't know what it was. And then sometimes I'd go get a nurse that's been a nurse for 30 years and she'd listen and she'd be like, wow, I'm not for sure. That's how difficult they are. Because they all sound different on different people. It's not going to be like a mannequin. It's going to be different, okay? So, rhonchi. Rhonchi is low-pitched, coarse, loud, low, snoring, or moaning tones. Its actual sounds like snoring. It's heard primarily during expiration, but may also be heard during inspiration, and a cough may clear it. Where did I tell you rhonchi can be heard at? In the front. They can also be called snorasuises, which I've never heard them called that ever. But here's what I'll tell you about breath sounds, which you need to know for all intents and purposes going out doing an examination at your level. If you hear abnormal breath sounds, have your patient deep breathe and cough. Can you take a deep breath and give me a good strong cough? A lot of times it's just phlegm stuck in their throat. If they can expel it, then the breath sound goes away. Okay. Stridor. Do we have any questions on stridor? Stridor is the easiest one, but it will be the one that you will hear the least. Stridor is very rare. It's a continuous musical sound of constant pitch. It results from a partial obstruction of the larynx or trachea. This is bad. You have a patient with stridor, it is bad. Children get stridor who have serious RSV infections, respiratory infections, they can get stridor. Lexi.
What would be obstructing the larynx or trachea?
Oh, anything.
Choking?
They could be choking, they could have something lodged in their throat, they could have respiratory depression where their trachea is not round and open, it could be closing off. You could be having an allergic reaction. Somebody who is having an allergic reaction and their throat is closing will also demonstrate stridor. Things can be stuck in there, Legos, car wheels, and so on and so forth. Children, you'll hear stridor in children. If you hear stridor in an adult, they're probably dying. A wheeze is a high-pitched musical sound similar to a squeak. It is heard more commonly during expiration, but may also be heard during inspiration, and it occurs in the small airways. It's also called, well, you don't even need to know that. A pleural fiction rub is also very uncommon, but you will hear this from time to time. This is a superficial, low-pitched, coarse, rubbing or grating sound. Questions? For all intents and purposes for what you need to do right now and throughout your nursing school career, you need to know how to identify them, okay? If you hear an abnormal breath sound on one of your patients, come get me.
do have one question, I guess. Because when we're documenting or, saying about what we hear, should we do crackles or should we call it rails?
Either or, I don't care.
Okay, it doesn't matter.
Doesn't make a
I was
difference.
like,
What's
It's
I'm used to
interchangeable.
rails, but
what's the most common sound we might hear in a hospital?
The most common sound would probably be rhonchi or crackles. Rhonchi is gonna be any kind of sickness, any kind of upper respiratory infection that you deal with. Crackles is gonna probably be, anybody who has pneumonia would have coarse or fine crackles. Wheezes are gonna be your asthmatic patients or your patients that are recently taken off the vent. So, crackles probably.
What we can do if we cannot identify?
Go get somebody and have them help you.
What if there's no? Can we just make X-ray?
No,
It won't help.
no. An X-ray will tell you the cause of the breath sound, but it won't tell you what breath sound you're hearing. You have to train your ear.
and which one would be more for like the emphysema COPD? Would that be more crackle? Or
No,
is
that
more
would be more
combination of
wheezing.
More wheezing.
Wheezing and stridor. Because remember, the COPD patient and the emphysema patient does have an obstruction to their airway.
Mhm.
Their alveoli do not inflate. Question? Do not stress out about breath sounds. Do not stress out about breath sounds.
Is it really so important to identify what sound is?
Yeah, when you're on a med surg floor, the doctor does want to know what's going on. That can help them determine what diagnostic test to order. And so you do want to be familiar with the sounds, but like I said, there's a fine line between some of them. You know that you're hearing rhonchi if you can only hear it in the front. If you can't hear anything but normal in the back, then it's rhonchi. Make sense?
Mhm.
So what nursing is really just a process of elimination. We don't diagnose. So we're just eliminating. So you would eliminate rhonchi if you can hear abnormal breath sounds in the back. And if you can hear abnormal breath sounds in the back, then it's most likely crackles. A friction rub, you are going to be able to tell. So if you have somebody that comes into the hospital with, let's say, pleurisy, then you're going to be able to hear a friction rub. That's very rare. I think I've heard it twice in my career. So the most common ones are going to be rhonchi and crackles. I've heard stridor a lot, but that's because I dealt with a dying
So you were
population.
with hospice, right? So you would hear it. So, I guess I'm kind of confused now because being from the EMS side, things, we always did the rhonchi rails when we documented, so you would never have both in the same, correct?
Mm-mm. Well, no,
Okay.
it wouldn't be.
Because they always said that if you heard the rhonchi, or you heard the rails, then you always were gonna hear the rhonchi too.
No,
So I'm like, okay,
rails are crackles.
okay.
And you're gonna hear crackles. You can hear crackles in the lower bases, or you can hear crackles in the upper bases, or you can hear crackles in all lung fields. And that's how you would document it. Crackles osculated in lower bases, bilaterally. Crackles osculated in all lung fields. Most of the time with your nursing home patients that you'll be assessing, you're going to have normal breath sounds. So I guess the easiest thing to do is identify what normal is. So if you get good at identifying what normal is, then, okay? Other questions? Comments, concerns, anything? No?
You said most of our patients in the nursing home are gonna be normal breath sounds? So, I feel like a lot of people in the nursing home would have like a lot of respiratory problems sometimes, like those asthmatic people or the COPDs or the emphysema.
But asthmatic people are only going to have abnormal breath sounds when
If
they're
they're
having
having
an
an
asthma
attack,
attack.
yeah.
And they're not gonna be in the hospital if they're doing that, they're gonna be in the nursing home, they're gonna be at the hospital. So asthma attacks are very few and far between.
I went into Morris ER and they O2 said me at 82.
Yeah,
I couldn't speak.
right. Yeah.
is bad.
So asthma attacks are triggered by something. So
Mhm.
most of the time, by the time you get to be 80, 90 years old, you know what the triggers are and you avoid it. Most triggers are outside. So our geriatric
Yeah.
population isn't outside very much.
But like sicknesses like this triggers mine
Right.
horribly.
Oh, yeah, I'm sure.
Mhm.
So your elderly population isn't sick.
Yeah.
I mean, they might have chronic diseases, but I mean, I took care of lots of patients in the nursing. I took care of a 102-year-old woman who didn't have one medication. Not one.
Yeah.
102.
And she
You
lived
know?
102 too, because
She was
no
102, you know what I
medications.
asked her? I said, what's the secret of life? You know what she told me?
No medications.
Lots of whiskey. And she said,
We had one that said avoid men.
yeah.
I was like, that's a good one, okay.
So just keeping that in mind, so now when you're in the hospital, it's gonna be a little bit easier because you're going to be dealing with a sick patient. So this first 8 weeks isn't about sickness versus health, it's about assessment. Just getting your feet wet and learning how to just assess an overall individual, head to toe assessment, looking at their skin. We're just trying to hone these little skills that you will perfect, you know. By 12, 11, you should be able to identify issues. You'll be able to document issues. You'll be more spoken. You'll have, you know, 2 full semester or a full semester on it. By the time you get to next year, you should be independent. You should be out on your own. You'll learn more about the disease processes next year. That's what next year is for. This year is just about learning the basics, taking care of the patient. And remember, nurses do not diagnose. All we do is report our findings. Okay? Touched it? No? All right, you guys can go. Have a great weekend.